Welcome to the Marvelous Middle Age Podcast, where we are building a community of people who are in the midst of midlife, sharing our stories and learning from each other along the way. Each week, I'll have a guest join me to discuss a topic that impacts our lives and touches on some aspect of midlife. We'll discuss relationships, transitions, health and well-being, parenting, careers, and more. My goal is to encourage and support you and help you thrive as you navigate this adventure of midlife. Join me here each week for the Marvelous Middle Age Podcast. In the third episode of the Let's Talk Menopause series, Dr. Teggatz shares how hormones affect us during perimenopause and menopause. We discuss hormone replacement therapy and the impact of the now debunked Women's Health Initiative study. While we discuss in depth about hormone replacement therapy in this episode, this route may not be for everyone. However, you choose to address your symptoms is totally up to you, and you should choose what you believe is the best route for you and your health. If you haven't already listened, be sure to check out the first and second episodes of the series. Dr. Teggatz and I provide an overview of perimenopause and menopause, including symptoms, how to best take care of yourself during this time, and what you can look forward to during the rest of the series. I am here with Dr. Tanya Teggatz, and I would like to welcome you back to the Marvelous Middle Age Podcast.
Thank you. It's great to be here.
Well, I'm so glad you're here. I have been waiting with bated breath for this episode because we are going to talk about hormones, and women who are believing they might be in perimenopause or menopause. Hormones is a big topic. That's what you hear a lot about. That's what people are asking about. And I think there's a lot of myths about hormones, things that, maybe in years past people believed, but are now being, demystified and debunked in a lot of ways. And so today's episode is all things hormones. So before we get too into it, though, let's talk about hormones. What are the primary hormones women should be paying attention to in middle age? What are those hormones?
Estrogen, progesterone, and testosterone are the main ones, but also a little talked about hormone DHEA, which is a hormone in and of itself, but it's also a precursor to testosterone and estrogen.
Okay. So tell me about the impact that perimenopause, menopause has on our hormones. What is it doing to them in our bodies?
Sure.
What happens?
So beginning in perimenopause, the ovaries stop producing hormones as much as they previously did. And it usually starts with loss of progesterone, with the absence of ovulation, a month here and there. And then gradually we also start producing less and less estrogen. Not in a steady way, however. It's kind of estrogen will go up and down while gradually eventually going down. And then testosterone also is produced by the ovaries. It's also produced by the adrenal glands. But the ovaries produce less and less testosterone as we age as well.
Okay. So all of those are getting impacted as we're in this stage, and to varying degrees, and different people will experience that differently, and it's kind of all over the place.
I should also say the DHEA. See, I forget about DHEA.
Good old DHEA.
Is produced both by the ovaries and the adrenals. And so as we age and go through menopause, the ovaries produce less and less DHEA.
Okay. So when we talk about hormones and those ebbs and flows and ups and downs, what are symptoms or signs? Like if someone's like, well, I think I might be in perimenopause, what are those symptoms that someone might recognize in themselves that might lead them to think, oh my gosh, my hormones are starting to go all over the place? What are just some of the obvious things that people might see?
I'll kind of go chronologically what typically happens, although it is very variable. So again, progesterone typically will decrease first, and women will often notice difficulty sleeping and anxiety with loss of progesterone.
Okay.
And with estrogen, again, it kind of goes up and down while gradually taking a downward turn. Typically in the 40s, late 40s, early 50s, symptoms of loss of estrogen include hot flashes, where you could suddenly be dripping with sweat and very hot and feel flushed and have to change your clothes. Yeah. That's a severe temperature dysregulation. Or it could just be, suddenly feeling a little flushed and warm, but not the dripping
terrible
and sweat. And they can happen during the day, but often these occur at night and will interfere with sleep. Definitely. Brain fog is a very common symptom of loss of estrogen and can be incredibly disconcerting. People often, think dementia when it's not dementia. The brain loves estrogen, and when estrogen levels decline, we can have more trouble with memory and concentration and just forgetting things. And, maybe in our work, in our 40s, we're often at the top of our game career-wise, and you can suddenly have difficulty concentrating and performing your job the way you used to. So that's a big symptom that will bring people in. Vaginal dryness will occur with loss of estrogen. Sometimes that happens a little later because it does take some time to develop, which can lead to pain with intercourse and then can affect your relationships.
Right.
Joint pain, weight gain, fatigue. We see all of these things. Loss of collagen in the skin, which can give you kind of saggy skin, and kind of the loss of, bright.
Your skin gets dry and dull. And I've also heard like hair thinning too. Like you can maybe start to see your hair thinning.
And that can be with loss of progesterone and estrogen, and replacing these can help. But yes, definitely hair loss is another common one. Sometimes changes in bowel habits, constipation. And with testosterone, the biggest symptom I usually see is loss of libido, but a lot of people won't really notice. But if I point it out, they're losing their body hair, more flabbiness and loss of muscle tone in general, and loss of strength. Women will see
You'll
as
see
well.
That. Okay. Yeah. So when you were naming all those off, my head was going to all of the symptoms, or how they impact our systems in our body, right? So our body is impacted. We're having these symptoms, whether it be the brain fog, or it could be something with joint pain, or I've heard of, frozen shoulder, or
that's a really common frozen shoulder.
Yeah.
Yes.
And all this pain, or you mentioned vaginal dryness, all these different things. These different systems are systems in our body, like hormones. I think you had told me
every body system has hormone
receptors all over our bodies. So our brain, our heart, our bones, everything.
Can I just mention a couple of other symptoms that I forgot?
Yeah.
Mood. I'm sorry. That is a huge one.
Yes.
I mean, I mentioned anxiety with loss of progesterone, depressed mood, irritability. I mean, even as severe as, thinking about hurting yourself. These are not really uncommon. So mood changes, definitely. Yeah, it's a lot. Pretty much every organ system can be affected. Palpitations are another one. And actually the cardiologists, have told me women in their 40s, very common to, think they might have a heart problem because they're getting palpitations. And again, when estrogen replacement, those can go away.
Yeah. Yeah. It's amazing to me how many different symptoms, and you just mentioned a bunch. I'll put a link in the show notes to kind of some of the more, all those kind of common ones, but there's even oddball ones. Like I've heard people have said their ears are itching or they feel itchy all over, like their skin itches, which attributes to, like you talked about, dry skin and because of the loss of the collagen and things. I mean, it really can be very alarming, some of them, and some of them are just weird. Like you're like, what is happening to me? I've heard a lot of women who never really struggled with weight, especially in their abdominal area. Like you mentioned, the weight gain, like they're all of a sudden they have this belly that they never had. And like, they're like, oh my gosh, where did this come from? And it's really hard for me to get rid of it now. And this is all, it can be attributed to our hormones. So if someone's listening and they're like, yeah, I'm having a lot of these, how do you as a clinician measure whether someone is in perimenopause? I hear a lot of people say, well, I want my hormones tested. But from what I understand, that's kind of a moving target. Like you can't do a blood test and be like, yep, you're in it. It's kind of a whole bunch of things. How do you kind of go about that? And is blood work really the way to do it?
Yes, hormone testing can be difficult. I do sometimes use it, especially like if a woman has had a hysterectomy, but still has her ovaries, or they had an ablation and they can't go by their periods, which I failed to mention as well. Irregular periods are definitely
that'll get
a symptom. But so hormone testing, I reserve for just a few cases. Basically, age, first of all, anywhere perimenopause can start at age 35. And so, I mean, if you're basically 35 to 55, and especially late 40s, early 50s, I mean, your hormones are declining if they haven't, already declined. Yeah. So loss of your periods for a year, which we have talked about in the previous episode.
Yeah.
So if you're having these symptoms and your periods are becoming irregular and or you haven't had periods for a while, it's pretty likely that your hormones are at least contributing to these symptoms.
Yeah.
Certainly there are other causes.
Right.
I also have very specific hormone questionnaires that I will give to patients, and I will use these over time as we replace hormones. We see their scores improve. That's a really valuable tool for me.
Yeah.
But age, symptoms, what's happening with your periods. And then once in a while I will do some blood testing. The problem is if you're having irregular periods and we don't know, which day of your cycle you are, then normal for you on that day is variable. And we just don't know what normal is if you don't know where you are in your cycle.
Right. Exactly. So there's sounds like there's kind of a combination of factors that you look at to see where someone might be and if they're a candidate to begin hormone therapy,
right,
and that sort of thing. But it's not like this, like a lot of different things you might go to your doctor for, say blood sugar. You can do a test and it gives a number.
It's not.
This is not like that. So yeah, and so
Right.
and I think I've talked to some friends of mine who like just wish it was more simple, and I'm like, well, it's not really that as simple or straightforward as that. You have to look at a lot of things to see where you're at. But like you said, with age, your periods, symptoms, you can
usually
figure out.
And again, if someone really wants their hormones tested, I mean, we can, with a caveat that, this may not be that accurate.
Right.
But,
right.
Yeah.
You can try it. Exactly. So let's talk about hormone therapy, hormone replacement therapy. What exactly is that? What does that mean? And then can you clarify, because I see lots of terminology thrown around. I see bioidentical hormone replacement therapy or compounded hormone replacement therapy. Can you just kind of give an overall perspective of what all of that means? What does it look like?
Sure. So hormone replacement therapy, we are just trying to replace what women have lost or are losing because their ovaries are no longer functioning optimally. So we're just replacing. I use bioidentical. And what that means is, so chemically speaking, the hormone that you would be getting is exactly the same as the hormones that your ovaries would be producing. So that's what bioidentical means. It's exactly the same chemically. And compounded is an option. And what that means is I prescribe the hormones to a compounding pharmacy,
Okay.
and they take the raw ingredients, in this case, a hormone, and they prepare it in a certain way. And in this case, it's in an organic oil.
Mm-hmm.
And I can make it very clean that way, where there's no fillers. But it's made by a compounding pharmacist versus a manufactured medication, which the vast majority of medications are.
Mm-hmm.
They are made by a drug company, and then
Right.
you get them from your regular pharmacy.
Okay, great. So when you're talking with a patient and they say, well, I might be interested in doing this, what are some of the benefits of hormone replacement therapy in your opinion?
So just to make it really simple, it improves your quality of life. Basically, most, if not all of these symptoms, a vast majority of the time can be eliminated.
Mm-hmm.
That's the goal.
Yeah.
We try to eliminate your symptoms. So what women over and over tell me is, oh, I feel like myself again. I feel like, when I was 30 again. And, that's kind of the level of hormones we're trying to replace at about age 30 to 35. I'm not trying to make you a 20-year-old
Right.
again, but, a middle kind of level for hormone replacement. So improves quality of life. And then long-term quality of life continues by decreasing risk of certain diseases. And the big ones are decreasing the risk of cardiovascular disease, dementia, and osteoporosis and fractures, and also decreasing the risk of diabetes. So the number one killer of women is cardiovascular disease.
Yep.
And if you start hormone replacement therapy early enough, ideally around, or it can even be, before menopause, you reduce your risk of cardiovascular disease by 30 to 40%.
Wow.
Which is huge.
Yeah.
And women who take hormone, studies have shown again and again, can live up to 4 years longer. So longer lifespan plus improved quality of life.
Yeah.
And similar statistics with reducing the risk of dementia if you start early enough, 30 to 40%, and osteoporosis and diabetes about 30%.
My goodness. Yeah. And that goes back to my point about how our hormones affect all of the systems in our body. I think a lot of people think of hormones having to do with periods and libido and things like that.
Reproductive issues.
Right. Reproductive
but
things.
Much more than reproductive.
Until I started reading a lot about this, I had no idea how many major systems of our bodies that hormones affected. I had no idea. And it's just been an eye-opener to me. And it makes a lot of sense why women in our age demographics start experiencing, the brain fog things and the joint pain things and all the heart palpitations, because our hormones affect these major organ systems in our bodies. And so
and women need to know this. So I'm so happy you are doing this because just getting the word out so you can make an informed decision. Is this something that you're interested in?
Exactly. And whether you go the hormone route or you do something different, making that informed, educated decision is so important. So if you're a person who with their healthcare provider decides to go down the hormone replacement therapy route, are there any side effects to taking hormones? I know when you and I talked about it, and we'll get into my kind of experience later, you start on a very small dose and kind of build up, and each patient kind of figures out their ideal dose over time and observing symptoms changing and improving or what have you. But if someone was like, gosh, I want to do this, but what are the major side effects, if anything, that I might experience from these?
Yeah. So the way I prescribe hormones, as you're finding your correct dose, that is a process. And by that, I mean, as you start hormones, your hormone receptors that have previously been dormant they start to wake up as you're giving yourself more hormones. So you start to need more hormones. And so it's sort of 2 steps forward, 1 step back. You may get some symptoms of excess hormones as we're increasing the dose. So you back your dose down. Then a few weeks later, maybe you're having symptoms of too little. So your body, that's a sign that your body, you actually
Waking
need
up.
more hormones.
Yeah.
So it's a process that takes about 3 months for most women of finding your optimal dose.
Okay.
And I mean, that can be a little bit uncomfortable, not knowing, some of your symptoms improve, but then you get some other symptoms and changing your dose. Usually, if I tell women this is a process and you know what to expect, it's very manageable.
Yeah.
But so that is sort of a side effect, but completely manageable.
Right.
I mean, as far as side effects, again, when we're replacing what your body normally makes, I mean, there aren't really side effects.
Right. You're not going to like grow a horn out of the top of your head or something like that. Like you're not going to.
I mean, what I see sometimes is symptoms of too much. So we back the dose down and those symptoms go away.
Yeah. Yeah. And that's what I like about your approach. And you gave me a list of things I might experience if it's too much and I need to back off, or not enough and I need to increase. And so I feel really informed about how I'm going to go about doing this. And so I feel confident that I will know by how I'm feeling and things I'm experiencing what I need to do with any given dose that I do. So.
And I make myself very available to patients. I want you to call or message the clinic and ask questions, because I would rather we deal with the questions early than later on. And I don't want you wondering,
why
what to
am
do.
I feeling this way? Or, what should I do if this happens? Or
But it's a time where you really get to know your own body, which is a good thing. Not all women pay attention to what's going on. So I do ask you to pay attention to what's going on.
Well, I think you and I met, I even talked about, I'm going to even like keep a little journal kind of every day of like what I experienced, what I felt. That way, again, brain fog, I can't always remember. Maybe my brain fog will improve once I start the hormones.
Right.
But I don't, from day to day, I won't always remember how I'm feeling. So I'm just going to quickly jot down anything that I notice or don't notice about how I'm feeling, so that I can say, oh, maybe I need to increase this one or back off of this one or whatever.
Well, and then I do also want to make clear, after, like I said, average of 3 months, then you find your dose and the dose doesn't typically change.
Right.
Then you stay on the same dose. You don't have to keep figuring it out.
You don't have to keep going up and down and up and down. Yep. Yeah. I love that. Yeah. I love that. So you talked a little bit about the best time to start. When, I guess, is the optimal time? If someone is really interested in doing this, when is the best time to start? Is there a time when it's too late?
Yeah. So the best time to start is when your symptoms start.
Yeah.
If you have symptoms, if you don't have symptoms or they're mild, right around menopause is a really good time to start. And the greatest benefit for reducing all those long-term health consequences is within 10 years of menopause. That's when we see the greatest benefit. But I also say it's never too late to start. I mean, perhaps, so let's say a 70-year-old woman or a 75-year-old woman, it's more than 10 years after menopause. I mean, you can still receive benefits of hormone replacement therapy. So it's never too late
to start. And then can you be on them for the rest of your life? Is there like a window when you should like stop them or anything? Or
so research shows that continuing hormones indefinitely, I mean, again, unless
you have,
I'm not sure what it would be if you had some negative side effect or something. Continuing them indefinitely gives you the greatest benefit. Basically, when you stop, it's basically restarting the clock where, as if it were menopause. So your risk of osteoporosis and dementia and cardiovascular disease then will start to increase at that point. So, a woman could stop at any time, but
there's
I
no
guess there'd have to be a good
rules
reason,
around
and
it.
I'm not
Yeah.
sure what that reason would be.
Right.
To stop.
To stop. Okay.
Yeah.
So you could stay on them until you
Indefinitely.
pass away if you wanted to. Okay.
Yeah.
So that's good to know. Yeah. Because I've heard different things about that as well.
Well, and certainly, reassess if some new research comes out. But
Sure.
at this point, really indefinitely.
They're saying you can just stay on them. Okay. That's really good to know.
And there is one caveat I should say. If it has been 10 years after menopause, I do an evaluation of your cardiac status.
Okay.
Because there was one study that showed starting hormones after 10 years. If you have cardiovascular disease in that first year of starting hormones, there is a very slight increase in the risk of a cardiovascular event,
Okay.
which I certainly wouldn't want to contribute to.
Right.
But if you don't have cardiovascular disease, then there isn't an increased risk. So usually some kind of a test, a cardiac evaluation, if it's been more than 10 years, I always will talk about that with patients.
Yeah. Okay. That's good. That's good. So kind of to that same line of thinking, is there anyone who, because of some kind of health risk or something, who shouldn't consider HRT? Is there anyone that you're like, yeah, if you walk into my clinic with this, or this, hormones aren't an option for you?
Well, if you had an active breast cancer,
okay,
especially if it was estrogen or progesterone receptor positive, I wouldn't start hormone replacement therapy. Now, if your breast cancer had been treated and you were in remission, there's actually some evidence that hormone replacement can decrease your risk of a recurrence. I mean, that would be a case-by-case basis.
Right.
But so an active case of breast cancer, because I give estrogen topically, the risk of a blood clot is not increased with topical estrogen. Estrogen given by mouth increases the risk of clotting. So traditionally, anyone who had a history of a blood clot or was a smoker, because smoking increases the risk of clotting, that was a contraindication for oral estrogen. But since we're giving it topically, it's really not. Okay. So really the only absolute contraindication is an active case of breast cancer.
What about stroke? If someone had a stroke,
that is not an absolute contra.
Okay. Kind of a case by case basis. You need to do some evaluation of that person.
I mean,
and
if
look
it's
at
a
their
cardiovascular event and we're starting it after 10 years, I would definitely be cautious. So yeah, I would take that as a case by case basis.
Okay. Because that's the other thing too, and we'll talk about the good old WHI study here in a second. Yeah. But I think there was so much, fear for so long for women and their providers to prescribe hormones. That was unfortunate. Now that we know that study is not, it's not what it said it was. And so I think a lot of people have heard, whether it's from their mothers or just, I think there's still a little bit of a narrative out there, even as much as menopause and perimenopause have been in the forefront lately of the conversation. And so I do want to talk about that just a little bit. So can you just briefly, we don't have to go all into a ton of detail about it because that'd be a whole nother episode, but talk about the World Health Initiative study, why it was flawed, why, what happened, what it told providers, and then that impact that it had on women's health and why it was so problematic.
Okay. So the Women's Health Initiative, I will try to be brief. But there's a lot you could say about it. So it was a study that was begun in the late 1990s, and they stopped the study in 2002. Basically, they looked at, it was supposed to be a study of healthy women who were either given a placebo or they were given hormone replacement therapy. And then they looked at lots of different variables. They're actually still following these women, but they've, in 2002, they actually stopped the study early because in the arm of the study of the women who were taking an artificial progestin and Premarin, which was an oral estrogen that came from horse urine. So neither the progestin nor the estrogen were bioidentical, and they were given orally. So the arm of the study that had the progestin, there was a non-statistically significant increase in breast cancer in that group. Again, non-statistically significant, which means that the result could have been due to chance. And that's why they stopped the study early. In the arm of the group that had only the estrogen, there was actually a statistically significant decrease in breast cancer. But no one talks about that.
No.
So that result, they stopped the study, it got to the media, and almost immediately both doctors and women became very fearful and just stopped their hormone replacement. At the time, I want to say almost 70% of postmenopausal women were on hormones, something close to that. It was over 50%, I want to say. And I mean, that number just plummeted to, I think, like 18% very soon after that study. And a whole generation of women, unfortunately, have been robbed of the treatment of hormone replacement and all of its benefits. So, okay. So why it was flawed. First of all, the women, it was not a healthy population.
No.
And the average age of the woman was 63, which, as I mentioned, most of the benefits are seen in the first 10 years. And so when it started, they were 63. That's past that window.
Right.
75% of them were overweight or obese. So not a healthy population. I think half were smokers. I think half were on blood pressure medicines. So it wasn't a healthy population. And after they stopped the hormones but continued to follow the women, they soon saw that non-statistically significant increase in breast cancer completely went away. And actually, the women that eventually got breast cancer, if they were on hormones, they had a lower risk of a recurrence and they lived longer. I mean, and it wasn't a huge decrease risk, but it was there. Right. And so because of all of these reasons, the study was quite flawed. But unfortunately, the message has not gotten out even to physicians and to a lot of women. A lot of people are still afraid of hormones and think that hormones cause breast cancer.
Exactly.
And hormones don't cause breast cancer.
No.
Now, like I alluded to earlier, if you had an active case of breast cancer, hormones could make an existing cancer grow faster. And I definitely have my women do breast cancer screening. And they have a few different options.
Right.
So you do have to screen yourself for breast cancer. I mean, women who take hormones can get breast cancer.
Sure.
But they don't have an increased risk. They might even have a slightly lower risk.
Right. Studies are showing that. And I think I said world health. It's women's health.
Yes,
women's health.
Yeah.
Goodness sake. I've been reading a book that talks, I just read the chapter about that study and I just shook my head when I was reading it. I was like, you have got to be kidding me, because to your point, there is a generation of women that completely missed out on the protective benefits.
I see them
it's so
now
sad
when they're in their 70s and 80s, and my mother is one of them, and it's really unfortunate.
Yeah, it really, really is. And I will put a link in the show notes to this so that everyone can read for themselves and make their own conclusions and decisions. But I also agree that the message hasn't reached all the providers and all the women that it needs to, because you still hear people, like I've known people when I've talked about getting on HRT, they're like, well, you can get breast cancer from that. And I'm like, no, actually, that's not true. And, and the fear is, of course, so great. And so it's so hard. It's a big hurdle to overcome. And again, everyone will make the decision for themselves about how they want to manage or treat these symptoms or not.
I just want the truth to be out there, and everyone can make a decision. I mean, everyone does not have to be on hormones, but just know the benefits and the downsides, and make that decision for yourself. And then I just want to make two other points just about research. So that was that one study.
Right.
Everything up until then, I mean, it was the research pretty much showed that hormones were safe and had benefits. So then there was just this one. I mean, it was a large study, but then this study scared everyone away. And then since then, there have been many studies that have confirmed that hormones are safe. And there's also been a study that looked at the different modes of giving estrogen, and really the transdermal or through the skin route is really the safest and has the fewest side effects.
Right. Because I know some women do a patch, some do gears with the topical. So there's what I like about it is there's options based on what you're most comfortable with and what you want to do, and it gives you flexibility, and you know, I love that. So thank you for clarifying that and sharing that. That is something I wanted to make sure we talked about and touched on, because it's something I will still hear people tell me, like, well, you can't, or you can't be on them very long. I'm like, well, why the heck not? You know, it's not, it's the benefits so far outweigh the negatives.
And I do just want to say what I am telling you about hormones indefinitely. I mean, most traditional, you know, primary care doctors and gynecologists would not necessarily agree with what I am saying. Often after 10 years, they do want to stop hormones, but I still feel like that women would miss some benefits and also the quality of life issues. So traditional physicians often will stop after 10 years, or sometimes they still feel uncomfortable with prescribing hormones at all. So, you know, talk to your doctor, talk to different doctors. And if you feel comfortable, you know, looking at research, to certainly do that. But there are different opinions. Mine is not the only one, but my opinion is that hormones are safe and have these benefits
great efficacy
and can be given.
If you're enjoying the podcast, please follow the show to make sure the latest episode is on your podcast feed each week. I would greatly appreciate a rating and a 5-star review on the podcast platform you're listening on. It helps others to find the show. If there are topics you'd like me to discuss on the show, please email me at themarvelousmiddleagepodcast@gmail.com or direct message me on Instagram at Nicole Stute. Thank you for listening.